I have a very nice subject. It is already covering some tips based on the recommendation from the organizing committee. Just a quick questions. How many of you attend before a basic ultrasound training? Only few. Okay, so I make it more simple. I think you have to start the slides from the first slide presentation. It's not. First present slide, please. Yes, okay. Bismillah. It's functioning, the clicker, please. Okay. Okay, this is my disclosure. I always like to present the teaching hall Azhar University. It is almost now 1,080 years still functioning till today. It's a 10th annual Congress for Saudi Society, so I come today with 10 stories in ultrasound. I tell you, 10 stories is actually in my clinic, how I use the ultrasound to help my patients. This is the interarticular shadow, the first story. All of us are visualizing the grayscale imaging between the variant of the black side and the white side. So I'm telling you here, when we see a black shadow inside the joint, we're expecting to see. We have different images, all of them are black inside the joint. So when you see the intra-articular shadow inside the joint, we call it the joint in black. Sometimes it is normal, and most of the time it is abnormal. Just a quick differentiation, I think Dr. Basant speak about of them. So the first concept, why you are seeing black shadow in the ultrasound. It depends mainly on the reflection. The transducer itself, it works in two different ways. First time is an emission of the ultrasound wave, and the second step as a receiver of the ultrasound waves back to the transducers. And the black shadow, it is already not reflecting back a significant amount of ultrasound waves. That's why it appears as a black shadow on ultrasound screen. And this actually defined the most hypoechoic or anechoic normal structure inside the joint, which is the hyaline cartilage. Hyaline cartilage is defined by the homogeneous anechogeneity or hypoechogeneity, or in other terms as a black shadow intra-articular, covering the articular plate with well-defined differentiation from the synovial side and the bone side. That actually does happen due to the high content of water, over 70% of water with a few amount of cells and collagen fibers. The most important, all of us looking for the abnormalities, the interarticular hypoechoic or black shadow comes from two common lesions of joint inflammation, which is effusion and synovitis. All of them are variant of black or hypoechogenicity, and you have to play your tips and tricks to differentiate between them. So effusion and synovitis appears as interarticular, hypoechoic or black shadows. Differentiations come mainly due to the pressure of your probe. So you have differentiated by the pressure and displacement of the fluid signal or hypoechogenicity, as I'm seeing here, that we can compress or disappearing the signal completely under the pressure of the probe. This is representing the fluid signal or ultrasound, and compare it to the displacement could happen for the synovial proliferation that is poorly compressed and non-displaced under the pressure of the probe. It's the first differentiation trick between the interarticular hypoechoic shadow. The second most important, which is the Doppler signal, but is not always there based on the activity of the joint inflammation, that the fluid or effusion doesn't present a Doppler signal, while synovitis, if it is active, also you can see a Doppler signal inside. This is the basic differentiation between synovitis and effusion. One more advanced, we can use it in some advanced techniques using the elastography in some situation to differentiate the tissue characteristic and elasticity based on the variant of the blue, green, and the red for the soft. At some time with tense effusion, you cannot displace the fluid, so if you have elastography also can help in some mixed lesions of fluid and effusion. Second story about Mr. Chris. He came to my clinic with this shoulder. He cannot abduct the shoulder significantly on active motion. And this clinically we call it as impingements, and I will tell you what ultrasound could help in this patient in the real scenario. We're examining the lateral part of the joint. This is the impingement sign or dynamic test to see the smoothness of the movement of the supraspinatus tendon under the tip of the acromion in dynamic scan. And your target here to see the two bony tips of the acromion and the humerus with accommodating the supraspinatus tendon in dynamic movement, and we cut off points here of 7 millimeter. If it is less, it means that the bony impingements. If it is normal, could be also still possibility of soft tissue impingements. In the cross positions, main target to assess the tendon itself in the short axis scan with the humerus, and you have a small line here representing the subdeltoid bursa. It's normally seen as a very thin line, already not interfering with the dynamic motion of the shoulder, which already it acts as a protecting cushion for the tendon from the surrounding bony landmarks of the acromion and the head of the humerus. This is a normal appearance of the triple layer of the deltoid, supraspinatus, and the humerus with the line of the bursa in between. But what's happening in Mr. Kress, which is distension of the subdeltoid bursa with significant impingement of the tendon during dynamic motion, and you can see the ultrasound image here representing distension of the hypoechoic shadow of the bursa, which appears as hypoechoic line with some irregularities of the deep part of the tendon attachment as enthesitis. You can see the fluid distended inside the subdeltoid bursa, already interfering with the dynamic motion on abduction of the joint. On the ultrasound, real-time aspiration and injection, and the ultrasound efficiently, we can see the on-spot improvement of range of motion in real-time injection using ultrasound-guided intervention. Third story is about Justina. She's come to me with hip pain, just for assessment, anterior hip pain. And for you, as already most of them are attending basic, the anterior part of the hip, we mainly concerned about the joint recess. We're starting our broad position to be parallel to the femoral neck and progressing toward the joint recess. And this is the anatomical corresponding part. We have the anterior capsule enforced by the ligaments. This is the neck and head of the femur with the glenoid on the left part of the screen. This is the cartoon representing the position of the probe. Your main target here is to visualize the joint recess to define if there is synovitis or effusion inside the anterior joint scan with the covering corresponding muscles, the iliopsoas, the sartorius muscle, and the rectus femoris on the anterior scan of the hip. Usually, the joint recess appears as slightly concave. We have a cutoff point of 7 to 9 millimeter, and if you found the joint recess convex, it means a high possibility of the presence of synovitis or proliferation. And I'll take you back to the initial photo here. As you can see here, a distension or convexity of the joint recess. So patient with hip pain, convexity on the anterior recess, a high possibility of hip synovitis. This is very important for us. But there is a very important lesson here. This is Justina hip in the same assessment with just rotation of the foot. Rotation of the foot is a very important part that can change the shape of the anterior hip recess. So the standard scan measurements already measured on the slight external rotation of the hip. That's why the measurement 7 to 9 millimeter taken on the external rotation, and the same patients, if you do it in internal rotation, you can see a slight convexity and a false signal of synovial thickening that could really give the false diagnosis of hip synovitis. This is the Koski's slides representing the same. You can see the change in the hip recess signal. So if you're going to assess the anterior hip, you have to look for the foot of the patient to be slightly externally rotated. Fourth story about Peter. He's one of my patients that come. He is a really known patient with psoriatic arthritis. He was controlled under Cosentyx for many years, coming every 3 months to take his medications, and a very good response. One time to arrive to my clinic with an urgent appointment, coming in a wheelchair with one knee extremely swollen with dense effusion. This is a high extensive effusion covering the suprapatellar recess. And usually the findings that could be there in ultrasound in acute arthritis, just a synovitis or effusion. With a known patient of psoriatic arthritis, so the question of the adding value of doing ultrasound in such a case. But for Peter, we can see the extensive distension of the suprapatellar recess with a mixed signal of fluid with some synovial hypertrophy, which was not there in the previous follow-up. After aspiration and examining the knee joint in full flexion, we can see here a cartilaginous layer of calcification representing what is called a double contour sign. So double contour sign or gout, which already can happen prevalently in patients with psoriatic arthritis, can give a false signal of active psoriatic arthritis, and the value of ultrasound in defining crystal arthropathy is evident even in patients with overlapping pathological lesions happening at the same time. Double contour sign is one of the OMERECT criteria for defining and diagnosing gouty arthritis or crystal arthritis, defined as the presence of independent of angle of isonations, hyperechoic signals over the surface of the hyaline cartilage, could be partial or complete, regular based on the density of the crystal signs. Urate crystals already cannot penetrate the depths of the hyaline cartilage, repelled by the negative charge of the collagen fibers, and it was already mentioned even as the first criteria by Walter Grassi 2007 as a part of the important criteria for gouty arthritis. As you can see here, this is the double contour sign over the first MTB joints in patients with gout. Whatever you are changing the angle of the probe, still you can see the hyperechoic line with the scene surrounding representing synovitis and inflammation. In 2019, based on the OMERECT, there is quantification of the double contour sign based on the density, 0 for absent and 1 for the possible lesions, and grade 2 for definite but minimal lesions, and grade 3 for the definite and severe lesion of the double contour sign, a semi-quantitative score. So if you found the double contour sign, you have to also to mention part about the quantifications. Moving from this to regular finding in our clinics every day using the ultrasound scan. This is scanning of one of my patients with the ankle effusion, and you can see here the hyperechoic line covering the hyaline cartilage. So it could be a double contour sign for diagnosis of gout, but if I say this in my clinic every day, I will diagnose most of my patients to having gout. Because in most of lesions that if you have a fluid especially or above the surface of the hyaline cartilage in the middle of the screen, you can see a rim of hyperechoic or white line, which we call it as the cartilage interface. You have to differentiate efficiently between cartilage interface and double contour signs. There is a great overlap always there in most of our patients. But as a trick for the cartilage interface, it's usually present at the middle of the screen. And if you change the angle of isonation, it will disappear by the angle of isonations in comparison to the double contour. Double contour is always there. Double contour almost irregular, not finely defined, and can also be present at the periphery of the image as well as at the middle part of the image. So give me your hands, please. This is double contour or cartilage interface. Who will say double contour? Who will say cartilage interface? Okay, how many of you are silent? Okay, so describe here, this is a signal typically at the middle of the screen, and you can see by changing the probe orientations, I miss the signal at some points. Yes, there is some synovitis around, but this is actually a false signal of double contour attached interface. Okay, here, what they're saying, this is double contour or cartilage interface? Double contour, who said? Okay, who said cartilage interface? Okay, most is still silent. Again, it is the middle of the screen. Once I change the probe, it will disappear. So it's surrounded by effusion. This is again cartilage interface. Okay, what do you think about this? Double contour? Who said double contour? 3. Okay, who said cartilage interface? Only 1? Okay. So this is a patient with ankle effusions and extensive fluid around, so expected to see a signal over the cartilage and middle of the screen, so it is typically as a cartilage interface, but just wait for a second. I just put my needle and take the fluid out to aspirate it, so I abolish a little bit the impedance difference between the fluid and surrounding. When I take the fluid out, I can see the signal still there. So this is a double contour in a gouty arthritis patients. Some bit tricky, but you have to be already confident in your finding. So what is again? Double contour. Who said double contour? Okay, cartilage interface. Only 1, okay, good. So we can see here a typical double contour from the middle of the screen down to the periphery of the image, always constant, and also when you see my needle coming from here by injections and fluid around, you can see more clearly the full length of the double contour sign over the surface of the hyaline cartilage. Moving to Samer, he's one of my patients with psoriatic arthritis, stable on conventional medication for many years. He came to me with one swollen index finger. It is a hot, red, swollen finger in psoriatic patients. We call it as dactylitis. Okay? And dactylitis actually showing a full-blown clinical manifestations, and sometimes you can ask yourself why you should do ultrasound for a patient with dactylitis. It's already diagnosed on a clinical background. I'll tell you here a small tip about using ultrasound, why it is important, even if you are seeing dactylitis, to put your probe. So you can see here the distension of the polys, which already mentioned in the presentation of Professor Bassant. You can see here the flexor tendon, and you can see nicely distension of the tendon polys, which acts as a part of the functional enthesis and can trigger the inflammation and cytokine storm in patients with psoriatic arthritis. And even the Doppler signal is almost present around the polys at initial part of inflammation, while the rest of the image, tendon and the paratendon part, and even the joint itself, I will show it to you in the next image, is still normal. Dactylitis, all of us are trained like this inflammation of the whole digits, cover all the components of the finger or toes, that's representing the synovitis, enthesitis, and tenosynovitis as a part of the component. And this condition is pretty prevalent enough to cover almost 70% of patients at any stage of the disease, and also the combinations of synovitis, tenosynovitis, enthesitis claimed to be the fixed component of dactylitis, but with the updated data that we are getting from the radiography, MRI, ultrasound showing not. Actually, inflammation in dactylitis mainly happen on the poly site in the tendon wrapping. Sometimes extend to the joint, sometimes extend to the tendon itself, but this is not the common scenario. This happens only in 18% of patients with dactylitis, which carries the functional enthesis theory by Dennis McGonigal that the inflammation starts here as the poly attachments who can trigger the inflammations. And based on the GRAPPA recommendations, the first line of treating the dactylitis, it is local injections. And if you're injecting the finger and not knowing where the inflammation it is exactly, you can miss the response. If you are injecting the joint while the inflammation around the poly, you will miss the response in your patients. That's why ultrasound in dactylitis is an important. This is a cartoon representing the image of the Samer finger, representing the distension of the polys, while the tendon itself and the joint is completely fine. So inflammation in the dactylitis, still ultrasound can play an important role. Moving for a very important story here, which is bone erosions. For us rheumatologists, it's very interesting. Once you found erosion, you'll be happy in the diagnosis, okay? So I need your hands again in this already second MCB joint. And you can see this is the proximal phalanx, the MCP, and we have this step down abnormality. The typical definition of the erosions based on the OMERECT definitions. I will take you quickly for 5 important questions. Once you see a step down abnormality in the ultrasound, ask yourself 5 questions, please. The first question is, ultrasound is the right tool for defining the bone erosions, as bone is already one of the great drawbacks or limitation of the ultrasound. But the answer, I'll take it from this paper from Wakefield, 24 years old now, this paper, which compares the conventional X-ray towards the ultrasound and showed that the ultrasound is 5.5-fold more in the first year of the disease and 3.5 still more sensitive than X-ray in the second year. And even with the updated evidence from the Danish group representing comparison between ultrasound and CT scan, ultrasound performs very well in accessible parts in comparison to the CT. So the answer is yes, ultrasound is the right modality, but ask yourself again, it is really erosions if you are seeing any step down interarticular part as a part of the erosions or not. I'll take you to the OMERECT 2005 representing the step down cortical abnormalities in 2 perpendicular planes. This is definition at 2005. And with the same update to 2019. This nice paper, already revised by the team of Mikkel, Østegard, and Skodler from the Denmark. We revised the 336 hands using the modalities, the CT, MRI, ultrasound, and conventional X-ray, and to answer the question, is all the OMERECT definition already a real erosions or not? So I'll try to be a little bit fast. I look here for the ultrasound column, and you can see ultrasound perform very well in the sensitivity. You have 94% of detection of erosion as a very high sensitivity of ultrasound. But if you look for the specificity, it's falls down to 67%, which means we have a gap about 27% of specificity towards the sensitivity, which means, in other words, that in each 4 erosions that we are seeing, at least you have a high suspicion of one of them is not a real erosion. So what the ultrasound is defining exactly? There is a lot of what's called erosion mimickers or pseudo-erosions. It can be already cortical notches, it can be blood vessel signals, or sometimes even small parts can already be mistaken as a part of the erosions. Erosion mimickers or pseudo-erosions usually present at some times of cortical abnormalities that could happen normally in some hands, especially at the site of MCPs. I'll take you again for another important paper already examined 100 MCP joints or hands in normal populations, and you can interestingly see with ultrasound that we have, at least in each subject of them, we have one lesion fulfilling the OMERECT criteria of bone erosions, and at least 99% over 100% of them have a bilateral lesion in both hands on ultrasound. So just take care if you're already defining erosion with ultrasound, and this usually present at the MCPs, especially in the dorsal aspect, on the central locations as a cortical notches, and in some carpal bones, the unitary tracheatrium and distal ulna. This is typically the cortical notch present just deep to the dorsal recess and in 2 perpendicular planes. It is fulfilling the OMERECT criteria, but it is at the central locations, not on the marginal side. And again, on the carpal bones, this is a lunate, it's a common depression. You can see it on the long scan of the dorsal rest. Second mimicker, which is the blood vessel, usually appears as a small notch, less than 0.6 millimeter, usually present at the palmar side, not on the dorsal side, and they can be seen in long axis and corresponding to the peripheral pulsation. Sometimes the small step-up cortical abnormalities of osteophytes at the MCPs appears as with the acoustic shadowing representing mistaken as erosions. Third questions, from where we can look for the bone erosions, and we can see it is already merely in the bare areas, around mainly first, second, and the fifth MCP, and already we have regular sites sometimes showing the Doppler signal, and the most important is the related synovitis. You have to look for the whole scene of the joints that represent this erosion, is typically erosions or not. Fourth question, how to define the impact? This is an important question. If you are seeing already based on the number of erosions, locations, activity, shape of erosions, which one of them could be already harm or bad erosions or not? The answer is difficult. You can imagine that you have an erosion at the first MCP joint, which carries 50% of the function of the patient hand, in comparison to 5 erosions at the little finger, which does not carry a good function of the hand. So the answer depends on the locations, activity, and sometimes the number of erosion, not only the size. I'll take you the most important scoring system that I'm using from Skudler, which already represent the normal, the fine irregularities as a part of grade 1, and the typical definition of a step 2 cortical break and two perpendicular planes, and the bone loss as grade 3 with a major defect. The description is important for you, as already in the initial part of the training, to cover the 4 S's: size, site, shape, and scenery. The most important always describes the scene around the bone irregularities if there is inflammation, synovitis, or Doppler signal around. So is this an erosion or not? Who said erosion? Who said not erosion? Okay, good. So this is not erosion. This is the middle of this dorsal. Deep to the dorsal cells, this is just a cortical notch, not an erosion. Here is a very abnormal finding. One of the patients come to me with a known diagnosis of the chondromalacia, so just come for refilling of medications. I revised her file. In ultrasound scan, we are using the flexion about 40 to 30 degrees to see the infrapatellar vein, which is representing here site of inflammation. Here we're looking for enthesitis around the attachments of patellar ligaments or related bursitis around. This is the typical revision of the normal examination, and this is the typical finding. That's why you are examining 30 to 40 degrees to allow you to see distension of the suprapatellar recess. Here, this is the typical ultrasound image infrapatellar. You can see the ligaments and the tibial and patellar attachments. And this is actually on the normal side. It should be a video here. Okay. If you can see, this is actually a picture taken on the 30 or 40 degree. But we look for the patient in complete extension. You can see an intra-articular cyst or ganglion that causing impingement. This was the diagnosis. I think there is, if you can play this video, please. Hello, IT? If you can click on the video. The second one, please. You can see here with the dynamic assessment. This is a cyst coming down from the joint itself. This is an impingement of the infrapatellar fat, which already could be a variant, so we have to examine the knee in extension and full flexion. This is the knee pain of one of my patients with rheumatoid arthritis, and on examination with the patella, you can see here, this is step down abnormalities of the cortex of the patella. It's a typical picture of fracture of the patella and a minor trauma. Ultrasound also can diagnose fractures, and already confirmed by the MRI. It is not already seen on the conventional X-ray. And the follow-up, you can see here the line of the fracture on conventional X-ray. My last story here about a patient referred to me for local injection for trigger finger or stenosing tenosynovitis happening due to thickening or degeneration of the A1 poly mainly that already affect the function and mobility of the flexor tendon. But with this patient's Mahdiya, if you can play the video, please. You can see here a significant inflammation of the tendon and synovial thickening all over and around, which is not normal. We are seeing on the stenosing tenosynovitis, and this patient actually, by full investigation, found to have a late onset rheumatoid arthritis. This is all my stories today. I'm inviting you to join us in our ULAR projects with the ERA next October. So if you have interest, you can scan this QR code to be with us as an early registration. and thanks for the invitation. Thank you.